Thank you all for attending today's webinar. This is the third webinar in our 8-part series, Home Matters, Rethinking Aged Care Design, that we're running with Dementia Training Australia. I'm Genevieve Donnelly and I'm the Assistant Secretary from the Dementia Diversity and Design branch in the Department of Health, Disability and Ageing. I'll begin by acknowledging the traditional custodians of the lands on which we are virtually meeting today. I'm based in Canberra on the lands of the Ngunnawal people. I acknowledge and pay respect to their continuing culture and the contribution they make to the life of this city and this region. I also extend that acknowledgement and respect to other families with a connection to this region and any Aboriginal and Torres Strait Islander people who are here with us on the call today. There will be a Q&A session at the end of this webinar. Please submit questions in the Q&A function. You may need to click on the Q&A icon at the top of your screen to activate the function before submitting any questions. You can upvote questions that other participants post, and this will help guide which ones are directed to the panelists when we get to that part of the session. There is a difference between liking and upvoting functions. Liking a question won't change its position on the screen. Upvoting will help push it up the list of the questions there. We will attempt to respond to as many questions as possible. Questions and answers, including ones that we may not get to today, will be published in the Frequently Asked Questions document on our website. Questions submitted during the registration process have also been considered for today's Q&A session. We sometimes receive questions that are unclear or not directly relevant to the webinar. During this session, we'll only be responding to questions relevant to today's topic. Other questions will be directed to the relevant areas of the department and addressed through the Frequently Asked Questions document. There is no option for attendees to turn on their videos or microphones today. Webinar slides are now available on our website. This session is being recorded and will be published on our website as well. Participants will be emailed links to the recording when they become available. Today's webinar aims to support aged care staff and designers to understand enabling environments. It will provide an overview of Principle 1, Enabling the Person of the National Aged Care Design Principle and Guidelines. It will explore how the physical environment and design features of an aged care home can help older people to maintain their health, well-being and sense of identity. Before we begin, I would like to acknowledge and thank the panel. We are very grateful for the time you've given to today's session and for the depth of experience and insight you bring to these discussions. We greatly appreciate your willingness to contribute to and support this important conversation. Today's session highlights how thoughtful, well-designed environments can support identity, choice, and everyday quality of life. Enabling environments are spaces that work with people, not against them. They remove unnecessary barriers and build in supports that help people navigate, participate, and feel at home. Principle 1 reminds us to start with the person. It's about designing environments that adapt to people. Environments shape our everyday experience of home. When we design with the person in mind, the environment can become a quiet and powerful enabler. I will now pass to Nick Seaman from Dementia Training Australia to host today's session and introduce our speakers. Thanks, Nick.
Thank you, Genevieve. Look, this is a great session. Thank you, everybody, for joining us and welcome. So first, the speakers we have today is we have Professor Susan Curl, who is a geriatrician practicing at Hornsby Ku-ring-gai Hospital in Northern Sydney and in a rural outreach capacity in Batemans Bay and in Maruya in the hospitals there in southern New South Wales. She holds the current chair in health care of older people in the Faculty of Medicine and Health at the University of Sydney. I was really lucky that the first time I saw Susan speak, it was when she was speaking to a community group, and I was really blown away by the way in which she talked really positively about what we can do and the way in which we can support people, and I just thought that was fantastic. So welcome, Susan. I'm also welcoming my colleague Liz Fuggle. Liz is a UK registered architect based in Sydney with over 20 years experience specialising in dementia and aged care design across the UK and Australia. She's contributed to a range of projects that relate to the general areas we're talking about, that relate to care homes, and she's the co-author of the national guidelines, has worked in training and advocacy. So she started off working doing work with Dementia Services Development Centre at the University of Stirling. She worked with Hammond Care Capital Works team with DSA, and now she works at Constructive Dialogue Architects, where she heads our strategy team. And I feel very fortunate to work alongside Liz, who consistently brings back the bigger questions we're talking about to what really matters to residents and how we can help them live their best lives. So again, welcome, Liz. So I'm going to, before we go into the presentation, so I'm going to give a brief reminder or a recap on the National Aged Care Design Principles and Guidelines. When I think about the principles, I always go back to my own personal experiences of seeing my grandmother, my father and uncle moving into aged care. And in the environments they moved into, I realised that there were a series of challenges that they had, which the environments weren't helping. And we have this legacy of buildings where we're trying to get the most that we can out of them. So when Liz and I were working through these principles, we tried to respond to four main issues that we thought were important, and holding those people in our minds, the people that we had our own personal experiences with. So the first one was thinking through the physical, sensory and cognitive challenges, the impairments people had, and that led to principle one, which is the one we're talking about today, about enabling the person. And in future sessions, we'll look at the other three. So just again, a reminder, principle two, responding to the fact that many environments do have a more institutional starting point. How can we shift those to be more home-like? That's principle two. Many people have difficulty getting outdoors. How can we support people getting outdoors? That's principle two. And many people in care homes are a bit disconnected from the world that they lived in, the community that they were a part of. How can we keep people connected with community? So those principles 2, 3 and 4 are the next sessions we're doing. And I'm going to pass over to you, Liz, now to unpack principle 1 for us.
Thank you, Nick, and thanks for that introduction. And it's great to be here and talking about the principles and guidelines. I love them. I love them. The honeymoon is not yet over. And I love that there are only 4 principles that I have to remember. And this particular one is probably my favorite, enable the person. So it really cuts to the heart of the matter. As Genevieve said, it's about the person, and that's everyone who's living currently in aged care. And we're wanting them to be enabled to, and the full title is to live in a place that maintains their health, their well-being and their sense of identity through design. And how do we do that? How does design do that? So a very simple example, and how I first saw this in practice was when I was a kid, because my mum was living with, for many years, a very significant eye impairment. And so from the time that I was born until the age of maybe 16, I saw day to day as a kid how the environment really added to her impairment. So I was highly acutely aware of the environments that were good for her and that were not so good for her vision. So one of the main things was the use of light. It could either disable her if it was glary, or if the light was really good, she could see someone's facial expressions. She could, that would enable her to have a better conversation, a better connection with somebody. And so the light really transformed her experience. So the first thing about principle 1 is that it changes lives. Like if we actually make these changes, it makes a difference to people's lives. The second aspect of the principle that I love is that it applies everywhere. So while this document was really written for aged care environments, principle 1 can be applied literally from a library to an airport to your home, anywhere that you want people to be more independent, anywhere that good design matters, and I'd argue that's everywhere. The third thing is that applying principle 1 really gets you off on the right foot for the 3 other principles. So creating a home, getting outdoors, connecting with community. If you do principle 1, then you're well on the way to actually getting the other 3 pretty well nailed as well. And then the fourth thing, if I'm allowed a fourth thing, Nick, is that this principle is actually quite easy. So most of the things on this list are quite common sense, or they can be worked out by science. So you can know your light levels, you can know what your light reflectance values are, you can know what your reverberation time is that you need, or you can work those things out or get a consultant to help you, and you should be able to apply it without too much debate. So yeah, principle 1, enabling the person, changes lives, applies everywhere, great place to start, and most of it is common sense.
Thanks, Liz. So in each of these sessions, we try and really start with the person and look at, in this one, as Liz said, it's more broadly applicable than just in aged care homes, but we will talk about aged care homes where many of these issues are most intense. But we wanted to start with Professor Curl, with Sue going through an introduction to the cognitive, the physical, the sensory impairments that lead people to move into care homes, and how we can understand them to build a little bit on that in terms of what we can do, what the physical environment can do. So Sue, over to you.
Thanks, Nick, and thanks, Liz. I think we all age slightly differently, but there's consistent underlying age-related changes, and it's not just wrinkles and grey hair. All our physiological systems age. So our vision, our hearing, our balance, our cognition, our bones and muscles, our liver, our kidneys, our heart, everything ages, unfortunately. They all deteriorate to some degree, but at different rates in people. Now, these are normal age-related changes. Then you add to those some of the pathological changes. And if we think of vision, we're thinking macular degeneration, glaucoma, cataracts. If we think of cognition, we think of dementia. Physically, we think of frailty, which is particularly around muscle, loss of muscle and mobility. Think of osteoporosis and the increased risk of fractures, and just falls risk generally. So you can see how we really need to adapt our approach to design if we're designing a home environment for older people with a number of these impairments. And unfortunately, it's the people that come into residential care that have these. So if we look at our older people, those people who need residential care, so clearly already have a degree of disability, they will invariably have at least 3, if not more, of the conditions I've mentioned. Some may be physically robust, but have dementia. And then you've got the issues around memory and day-to-day function. They require regular supervision. They require prompting for activities. Some may have changed behaviours. So having a friendly, familiar environment in which these people can live comfortably is just so important. We also see people who are physically frail. They have very poor mobility, high risk of falls. So again, we have to have an environment that allows them to reduce the risk of bad things happening. I guess when we come to vision, and that's what I'll talk about first, most older people will have problems with vision. You know, we all become long-sighted as we get older, but then there's the other problems I mentioned, macular degeneration. So people can't see very clearly, they can't see fine print. They have some real issues with recognising faces or what's on a table in front of them. Glaucoma leads to problems with peripheral vision, so they don't necessarily see what's one side of them or the other. Untreated cataracts, it's like staring through a veil all the time. And it can just be as simple as not having their spectacles on because they've forgotten them or lost them. All those sorts of things contribute to problems with vision. But I want to emphasise particularly the issues for people with dementia. And we're looking at 55 to 60% of our residents in care who have dementia. There are visual problems specific to dementia. There is actually something called the visual variant of Alzheimer's disease, where there are very specific visual problems. But what we see commonly is poor contrast sensitivity. So even if their vision appears normal, their eyes are normal, they cannot see the edge of a step or the edge of a seat. They can have poor depth perception. So they can't judge how far away that chair is to sit in, or how far away the cup is to have a drink, or where the pen is that they're trying to pick up. And often there will be misidentification of objects, and that can then lead, particularly in people with dementia, with say dementia with Lewy bodies, they can lead to visual hallucinations. Having adequate lighting, not having the shadowing, that sort of thing is really, really important if we're to support our older residents with visual problems. And I'd probably like to hand over to Liz now and say, okay, Liz, I've described the problems. How do we deal with those?
What do we do about it? Yeah. Look, it's so important to highlight the difference between, you know, visual impairment and the impairment that comes with dementia to the visual cortex. So what we're trying to do through the environment is to make it as clear as possible. So giving people the best chance to see. So there's two major areas. So there's lighting, improving lighting, and improving tonal contrast. So first of all, light, that is the thing that enables us to see. So without light, we're literally in the dark and bad things happen. So the other night I got up in the middle of the night just looking for a blanket in the dark, totally smacked my head off a shelf. That was a bad situation, but it was just because it was dark. You know, I knew the shelf was there. If it'd been daylight, it would have been fine. So if we have low light levels, people are going to struggle, but particularly for older people, there's less light getting into the eye. And so we're actually looking for around double the amount of the normal lighting level that you would expect. So for me, a good rule of thumb is 300 lux. So light's measured in lux levels. And you'd want more than that, more than 300 on a work surface, and you could get away with less in some spaces, but 300 is a good kind of benchmark. And you can measure that with a lux meter. You can download one on your phone, or you can buy a professional one for about $300. It's really important to check what the light levels are like in your care environment. So if people are falling in corridors, really good to check the light level, because it may be very, very low. It's good to know that the best and brightest source of light is always daylight. Daylight's so bright, it's easily 10,000 lux as soon as you go out of a door outside, and it also has the best color rendition. So if you want someone to be able to read or read a magazine or do a puzzle or knit, it's really important to try next to a window or sit outside. And that's also, it's going to be great for their sleep as well. So I think it's definitely worth checking. If someone stopped doing an activity that they loved, it might just be the light level that is limiting them. It might just be their vision. It might not be dementia or anything like anything more complicated than just a lack of light. So try sitting next to a window. Next slide, please, Megan. So then the second thing is about tonal contrast. We're trying to ensure that someone can see the shape of the things that they are looking at as clearly as possible. And you might have heard a lot about color contrast, but the main thing that makes the difference for us to be able to see something is the contrast in tone, which is the lightness or the darkness of an object against its background. So we see this a lot in public spaces where, by the building code, we need to have tonal contrast on the edges of steps. So in a train station, on a stair, there needs to be 30% light reflectance value level of contrast on the nosing. So this basically means a dark strip on a light stair or a light strip on a dark stair. And it's this difference we're looking for to enable better vision. And that can apply everywhere that we want to highlight a thing. So a chair against the floor, and a toilet, like in this example here, the toilet against the walls, and against the floor as well, and the pan against the seat, those sorts of things. So I'm sure lots of people know this trick, but if you take a black and white photograph, that will show you the tonal contrast of the objects. So, it doesn't matter if things are blue or pink, whatever color they are, it's the actual lightness or darkness of the material. And that just means that someone can see and find and use the thing that they need to to find. And it prioritizes and simplifies visual information so that people are less overwhelmed. So that's kind of the simplest thing you can do, is really to consider more light in the environment, and then taking photographs to check the tonal contrast, know your lux levels, and know your light reflectance values.
Liz,
sorry,
can I jump in, Nick?
Yeah.
I just want to mention the issue of toilet seats.
Yes.
We had masses of falls in our hospital. I know we're talking about aged care homes now, but the hospitals were very similar. And when we had a look at the toilets, they were all white.
Yep.
And people, even without major visual problems, were having problems. Going to Bunnings and walking out with 21 black toilet seats was an interesting experience, but it made a huge difference. And we cut the rate of falls by about 75%. It was as simple as that. So I think, you know, it's not necessarily rocket science. As you said before, it's often common sense. Sorry, Nick, I'll shut up now.
No, it's fine. It's fine. I also think we want to focus on the easy wins. And when you mentioned spectacles, so just to say, there are 3 different pieces that we're going to go through today. The first one's vision. We're about to move on to the second one. But before we do, I think it's important that we know what can people do now. And as simple as it sounds, a cousin of my father's was an ophthalmologist, and she got really annoyed when he had dirty glasses. And so the simple wins are, when people have got glasses, cleaning the glasses, going back to what Liz said, opening curtains so there's more light, and what you've got on the screen at the moment, getting rid of clutter. These are easy wins that we know make a huge difference. The fourth then being something like the toilet seat. So we'll go through more of these as we go through the session today. But there are a lot of easy wins that people can do now, and they often feel that they can't, but they can actually make that change immediately. The second one that second session we're going to go through, that I'll ask you to go into a bit more now, Sue, is looking at noise and sound and how we deal with hearing. And a lot of what we talk about, I think, excess disability, and that's where we start off coming to a place with whatever impairments and challenges that we've got, and is the building helping us? Is the place we're moving into helping us overcome those, or is it making the issues that we have entered it with worse? And so in terms of handing over to you, that's my challenge to you, is how do you deal with that issue when we're talking about our hearing?
Yeah. Hearing really is a challenge. For all of us, our hearing deteriorates as we get older. It's called presbyacusis, and it is normal age-related changes. You don't necessarily hear the higher tones, but if you've been working in any sort of industry, or even just using the lawnmower or the chainsaw without ear protection, you will have more hearing problems. And in Australia, we have a double problem. We have wonderful hearing aids that are available to people, but in Australia, 80% of hearing aids are in the drawer, not in the ear. So that adds to a lot of issues in terms of how do we have people as able as they can be. There really is a reluctance to accept deafness as a problem. People won't hear sounds, so sounds might be faint, they might be distorted. Hearing in a group can be really, really difficult. Hearing in a place with hard floors, so there's echoing. Just think what it's like in a restaurant where there's polished floors. And the noise level can go up hugely. So working out how we can adapt our environments to allow hearing to be more optimal for people who already have hearing problems. Certainly people with dementia not only have problems physically hearing, but their brain has trouble filtering out the extraneous sounds. So if someone's got the mixmaster going in the kitchen, they may not hear what you're saying to them a few meters away. If someone else is talking, even if someone's flushed a toilet, sometimes that noise is enough so that they don't actually take in what you're saying. And there's a few ways we can obviously deal with that. Coming back to Nick's common sense, easy wins. Speaking directly to the person. Older people lip read, and didn't we discover that during COVID, when I didn't realise how many of my patients really could lip read quite well until I started wearing a mask, and they wore a mask, and it not only muffles you, but you just can't see the lips moving. Obviously, putting the hearing aids in. And I have to say, I do prefer the hearing aids that go over behind the ear. They are much less likely to be lost. I actually had a patient in hospital whose gorgeous little hearing aids were on the bedside table. When his medication came that morning, he didn't have his glasses on. He got his glass of water and took his 2 hearing aids because he thought they were his fish oil capsules. They were about the same size. That was quite interesting. The bigger hearing aids are certainly maybe a little more obvious as well, so people can see that if you're wearing a hearing aid, maybe they need to speak clearly. And really importantly, it's having a quiet area where you can speak with one person or perhaps another. Speaking is such an important part of communication. I know that's obvious, but the number of people who do not hear what is being said to them is huge. And remember that hearing loss is one of the major risk factors for dementia, because we think it's because that stimulation, that their brain is not being stimulated because they are not hearing. They are missing out on so much. So if we can't always get the hearing aids in, what can we do, Liz, to make the environment nicer for older people so they can hear what's being said to them?
Yeah, absolutely. Well, there's 3 main strategies that we would recommend in an aged care home. And the first thing is to reduce the noise at source. And that starts really with us listening, asking residents and staff what noises bother them. And often it can be as simple as closing your eyes, writing down everything you can hear in an environment. We can also use a noise meter to measure the noise level. And it's good to do that at different times of day, particularly at night time as well, because we know that noise can be a massive impactor on sleep quality and how important sleep is to, all metabolic function. So thinking in care homes, there's so many different noise sources. We're really trying to eliminate the ones that are not domestic, that are not familiar, and that are intrusive. So things like trolleys bumping or squeaking, noisy air conditioning, commercial dishwashers, nurse call alarms, your 75 decibel leaf blowers, pill crushing, all that sort of thing. Heavy doors slamming, like often the door to the unit is a real noise source in itself. So what can we do to minimize those sounds? Can we move noisy activities to other places? Can we change the position of where the staff handover meeting is happening so that it's less intrusive? Can we fix anything through maintenance, like air conditioning units? Can we put some acoustic screens around the air conditioning units, that sort of thing? The second thing is about improving the acoustics of a space. So you mentioned, Sue, about those kind of noisy restaurants with hard floors and hard surfaces. It's really important to try and reduce the echo as much as possible in a space, reduce both the background noise level and the echo. So spaces which are going to be more echoey are larger spaces, rooms with not very much in them, and rooms that have hard surfaces like vinyl on the floor or lots of windows. And sadly, often many large communal dining rooms in aged care have all of those 3 things. And it's a problem in particular in a dining space because it can be so distracting to someone who's eating if it's a noisy environment. And so someone is not able to focus on their meal, and they're not going to eat so well if it's a noisy environment. So we can do things like reduce the echo by putting shears, acoustic shears on windows, adding in more soft furnishing, breaking up the space with furniture. If you've got a high ceiling, you could consider like a floating acoustic panel, which can absorb sound from below and above. They're amazing. And also installing carpet is really makes a massive difference. So it will absorb both impact sound and airborne sound. And you mentioned this already, Sue, but it's giving people the option of getting away from a noisy environment. So this image on the screen just now, I love. It's a end of a corridor space where there's nice seating, there's an access outside, it's got carpet, it's clearly a quiet space, a perfect place for a conversation, and it's easy to get outside as well. And got like lovely connection with nature, which it would be perfect for a conversation, perfect for some quiet time.
Whenever we look at carpets, we look at like you and I look a lot at the barriers that people put up as to why they don't do things. And so different people do relate to carpets differently. When various clients come and say to us, we don't want any carpet because we're worried about cleaning, we're worried about spills. Do you want to just talk a bit about what your response to that is?
I think that's really problematic because if you compare a care home that has carpet in it to one that doesn't, the acoustic environment is so different. The atmosphere is completely different. Carpet has come a long way in the last 5-10 years in terms of what you can specify. You can specify very high quality, easily cleaned carpet that is an impervious back that you can clean robustly. I think it's really important to look at what product you're actually putting down and choose a good product that's broadloom, has that acoustic back. And also the trouble often with carpet is that if there's a spillage, there's a tendency not to immediately clear it up. Unlike vinyl, because it's an immediate slip hazard, it would get cleaned very quickly. But with a carpet, things get left, and that often means that things will begin to smell. So you do need a robust cleaning regime, and it's just about immediately cleaning as soon as there's a spillage. And obviously there's places where it might be easier than others, but wherever you can think about putting in carpet, it does make a difference. So
again, with sound and noise, I think the important thing, the easy win, so to speak, of like the spectacles, is that a lot of the noise, and I think you touched upon this, but just to go back to it, a lot of the noise which exists in a care home is often institutional noise. And I think that that's something for everybody to be aware of. And in a room of 80 people, it is really hard to concentrate. And I know that as my father got older, we focused a lot on how could we get smaller groups of people, because he could engage more easily with smaller groups. So I think that busyness and that institutional noise are actually the challenges that we often deal with.
Absolutely. Yeah.
Going into our third issue, so we've talked about sight and we've talked about hearing. The third issue that we wanted to go through today, Sue, was looking at wayfinding. So the ability to move around a building is so fundamental of how we know where we are, how we move around, to people retaining whatever independence they've got when they come to a care home, recognising they're moving into a place which you said right at the beginning, you talked about familiarity. There's no question that you move into a place which you're not as familiar with as your own house. And so whatever mobility you've been challenged with at home, you're moving to an environment where that lack of familiarity is already going to make that harder. So how do you want to unpack that for us a bit and talk about how you relate to what we refer to as wayfinding or navigation, as people need to then find their way around a place which starts off pretty unfamiliar?
I think wayfinding brings together a whole lot of different physiological systems. So clearly you've got vision, you've got to be able to see where you're going. Hearing, because people can direct you. Someone might call, no, a bit further along, go to the left. If you don't hear that, you've missed out. It brings together memory. Do you know where you want to go? Do you know where you've come from? How do you remember where your room is if you're in a memory support unit? How do we put in the identification cues that allow a person to go to their room and not someone else's, with all the resultant problems from that. You've got to be able to walk. You've got to be able to mobilise. And as the lady in this slide, she's got a walking aid. She is hanging on to the handrails. So you've got to be able to mobilise safely without a fear of falling, which is always an issue. And being able to recognise what you've gone past. So you need to be able to think, okay, what is that person actually, why are they walking around? Are they walking to their room? Fine. Hopefully they've learnt that between the dining room and their room, there are certain things. But are they lost? Are they bored? Are they looking for their husband who died years before? What's their spatial awareness like? There are just so many different things that we need to look at. Certainly with my mother, who was in 3 different care facilities, aged care homes, over 6 years, and she was always in a smaller environment, and it made big difference when there's only 14 different rooms she can go in. It was much easier for her to recognise her room, because we made at the door, we had a big cabinet that was clearly hers and had her items in it. So as long as she went near to that, she recognised it was hers. But how do we address the problem with those people who just walk round and round and round? And I think Liz will come to try and decide or to describe the sorts of environments so that there's no wrong choice, no dead ends. And I was in a residential care facility down here on the south coast of New South Wales, where I am at the moment, last week, and one of my patients in the memory support unit, who shuffles around and gets round okay, and people can direct her, and she will go to where she thinks she wants to go. She went into a corner and was stuck there, and she was just shuffling, going nowhere with her face against the wall. And it took us to go over after a while and turn her, and then she could walk. So having dead ends was probably not a good idea. You want the environment where people can walk safely, so there aren't steps or trips or ramps or something unexpected. We often talk about the racetrack design. That can be good and bad. I've always been a proponent for bus stops, but Liz will tell you that's not always the right thing to have. They're wonderful outside. We've certainly used them within the hospital system, because people recognise a bus stop and will sit there. But that issue of all the different deficits that we've mentioned, physical, cognitive, sensory, really make wayfinding a major issue. And I think there's lots we can be doing to address that. So I'll hand over to you, Liz.
Yeah, I'm so glad you mentioned about the small environment, because we know that that is the best thing in terms of helping someone to navigate, is actually for the environment to be small and simple layouts, with a good hierarchy of public to private space. And like this image shows like a open plan connected spaces, so someone can just see somewhere to go and go immediately to that. But if many care homes don't have this kind of floor plan, or are much larger. You've got long corridors, like you describe. And I mean, there's key things with wayfinding. You want to make sure that lighting is good. You want to have meaningful destinations. So for the lady you were describing before, she got stuck, and you just don't want that to happen. You want someone to arrive at somewhere that's meaningful, that's safe, and that they can then turn around and come back again to somewhere else that is also meaningful and safe and helpful. You want to differentiate between different spaces, make sure they're easy to recognize, and differentiate between corridors. It's good to make corridors asymmetrical so that you can see what direction you're walking in. So if you go, down one way, it looks a certain way, and you turn around, you come the other direction, it looks different, because you've got is asymmetrical. Can you make sure that at the end of the corridor there's something that's visible? And then the other thing was landmarks. Now, before we came online, Sue and I were talking about landmarks, and you had a really good one that your mother used in the home that she lived in. Would you want to talk about that for a bit?
Yeah, there was a bench, basically standing height bench in the middle of the corridor that staff would use to fold clothes on, or you'd put things on, and they put magazines on that. For the men, there were car magazines. For the women, there were women's weeklies and country life. And that was very useful for the people in the corridor, that corridor where my mum was. As soon as she turned the corner and saw that bench, it was a funny wedge-shaped bench, she knew where she was.
Yeah.
And I think having that unusual, or that different, I won't say unusual, that different sort of landmark is important. Pianos, that was the other thing in the 12-room apartment dementia support unit Mum was in. There was a piano. Everybody would congregate. They would walk to the piano, even if there wasn't anyone playing. But it was a really good benchmark. And I know one of the men knew that was on the way to his room.
Yeah,
and he
fantastic.
always, that the staff would say, just go to the piano, Ken, and keep walking. He would almost invariably find his way to that. So having those slightly unusual landmarks can make a huge difference. The hairdresser, I was somewhere a couple of weeks ago and I was told by the care manager, I was looking for a resident, just turn left at the hairdresser and then right at the fire extinguisher. And this was in a facility with 80 different rooms. I needed those instructions, but I heard a little later one of the care staff saying exactly the same thing to one of the residents. Now, don't forget, you go left at the hairdresser. And so having those sort of different things, I think, is really quite useful. And again, very simple. It's not rocket science. I've said it before.
Yeah, absolutely. I think so. A good landmark is one of those things that really stands out. So you're saying the piano. You're only going to have one piano in your home, so it's not going to move. It's going to stay there. So it's very and it's also multi-sensory, makes a sound. And it's also traditional. It's something that you would have potentially had in your own home, maybe depending on the culture, but it's something that really would be a good landmark. So it's worth thinking of those things that will help people and putting those things at decision points. Like you were saying, that funny bench that seemed to work really well. It was at a decision point that someone might need to make between corridors. I think the other thing to say, next slide, please, Megan, if that's okay, is that out of sight is often out of mind, and that the converse is true. So if someone can see the place they need to go, then they're much more likely to get to it. And nothing is more important really than being able to find a toilet. So if we can reduce the number of steps or choices or decisions that a person needs to make in order to find their destination, that's really helpful. And often, people are labeled incontinent when actually it's a design issue. It's the architect's fault, and the toilet is just too hard to find, or it's not visible, or it's not recognizable enough. It doesn't actually look like a toilet. Everything is maybe white. So we're trying to reduce the person's effort, their cognitive load, by eliminating what they don't need to see, making it really clear what they do, using lighting, tonal contrast, and adjacencies. Yeah, another just quick thing, if I've got time, Nick, is just to talk about the flooring here. And Sue, you and I were talking about this earlier, that the floor is so important to make sure that's as clear and simple as possible. And this image on the left is a really good example of where the carpet in the bedroom, and it is carpet, has been matched tonally perfectly with the vinyl in the ensuite. And that just means that it's very easy for someone to see the toilet. That's the main thing. They're not worried about a threshold where a light floor is adjacent to a darker floor, which might look like a step to someone who has got not such good spatial awareness.
Brilliant.
So
Thank
that was
you. Just before we go into the Q&A, thank you so much for what we've gone through, what we've gone through with hearing, vision, and wayfinding. Before we go into the Q&A, I'm just going to make a brief mention of chat, the assessment tool that we developed to go with the book. So the book's written in a way that we tried to make as easy to read as possible. So the images you've been seeing today are images where we've given it to you as an image, a simple statement, and different ways of actually engaging with the material. There's a lot there that we've gone through, and there's a page on each of these to go into a bit more of a deep dive. But one of the things that really stands out for me working as an architect in this area is that what we go through, it's not whim or style or something we think is a good idea. There is a science behind it. And because of that, we wanted to really go through that process of we can assess an environment and we can look at what's actually happening and what's working well and what isn't. When we developed the tool, the care home assessment tool, the big focus we had was not good, bad, or otherwise, but how could we help people to see whether they were improving? So it starts off with it's an easy way, an easy app to use on an iPad, a phone, on a computer, and it leads you through a building to look at it through the lens of the principles and guidelines, and it leads people through what's working and what isn't. And the idea is that somebody who's using this can then say, oh, look at this. I don't think that I think our biggest issue is wayfinding, and so we're going to make a change. And you can do the same tool again after the change to demonstrate to yourself and to others that we're going through continuing improvement, we're improving things. Or if you're looking at something where you want to show somebody that an investment's going to actually be important, we're saying you can show here through the lens of this evidence base of the principles and guidelines, before we do this work, here's our assessment, afterwards we've improved it. So the tool's there, it's easy to access, and it's on the DTA website, and it's something which you can, it's pretty easy to go into. So please do go and use it, because it takes you through a way of looking at your environment differently and then looking at whether, if you make certain changes, it will work. Just before we go into the Q&A, just to go through a few other resources there. So you've got chat. This hub will take you to that tool. It'll also take you to a link to the principles and guidelines that you can download from the department's website. You'll also find a course that we developed a few years back that we're going through a slow revamp of at the moment, but which goes through the same material. And it leads somebody in 3 or 4 hours through a deeper understanding of the sorts of material that we've been going through today. So you've got the tool, you've got the book, and you've got a course that goes with it. We're going to now go through the Q&A. And the questions that we've got at the moment, there are a few questions that have come through. I'm going to just start though with vision and say, just to recap what we've been discussing, just putting up my own question to the two of you. I think that with vision, decluttering is a really important thing that people can do now. Like a lot of people on this call have got legacy buildings which they've basically been given with this mixture of problems. But other than decluttering, what are the easy wins that you look at that people can do to start to deal with issues that relate to vision impairments?
Liz, it's more your call. I do think though, taking what you said, Nick, make sure people have got their spectacles. I made sure my mother had at least 3 pairs, and they all had her name on them. And it was amazing when you've got them very clearly named, they come back.
That's good.
So that's just one way personally they can do it. But I know environmentally, Liz, you've got some great suggestions.
Well, I think one of the easiest thing is to ensure that curtains are opened in the morning, like as wide as they can be opened, because daylight is free and it's the best. And, you know, just in terms of people's circadian rhythm, it's really important to expose people to daylight. And people really should be getting outside every day in the morning, at least once a day in the morning. So curtains are a big thing. I do think it's worth assessing, just taking the lux meter even on your phone and assessing problem areas, and thinking also where are potentially incidents happening, where are people falling, or there's conflict. Is it that the light isn't very good? And so investing a bit of time to work out how to improve the light in those spaces. So whether that's, adding in additional lighting, and yeah, or even just painting the walls a lighter color, sometimes that makes a big difference as well. Yeah.
I mean, I think that's that next step after you go beyond what people can do on the spot in terms of opening a curtain. I think there are that question of most homes have some process of replacing flooring or doing painting. One of the questions that came through was somebody said the last photo showed a very dark floor, and I just wondered whether or not they thought it was a bit too dark. I just wondered whether you wanted to respond to that, Liz.
Look, I think if you're trying to get the contrast between the wall, floor, and objects, sometimes a darker floor can be helpful to do that. Especially in an ensuite where you're trying to get like maybe a mid-tone on the wall, so that the sanitary ware, which is white, is really going to pop. So there's that kind of calculation of of light reflectance values. I think you've got to be careful with dark floors when it is a small area of dark floor in amongst other lighter floors. Then that can definitely look like a hole, or it could like a step down. So you've got to be really careful. It's more about the change that might be on the floor rather than the darkness of the floor itself. It's very important for generally walls and ceilings to be light, but making sure that you're contrasting things against the wall. Sometimes feature wall can be really helpful as well.
And you and I have talked a lot that if we're trying to have a consistent floor through the whole of a building, then we're often with the design, we're starting with what is that tone of the floor? What's a tone that we can then continue out to a garden? So it's the same thing from somebody's bedroom to a living space, the living space out to the garden. And once you make that decision, that's going to affect what you then do with everything else. So once you've got, if the floor is light, you could do a darker wall. If the floor is darker, you're doing a lighter wall. So that leads us through a whole sort of a palette that is being built up from that floor as a starting point. In the hearing questions, and this one's one I guess that goes straight to you. So somebody was saying that because of hearing issues, it can lead people to eat in their bedroom where it's not so noisy. Do you want to just go into a little bit more about that connection with noise, sound, and social life, and what we can actually do to relate to that?
I think sitting at a table for a meal, and we know having a tablecloth makes a difference. It's important to have that social interaction and that conversation. But that being said, if a person can't be involved in that conversation, then they automatically socially isolate. Or perhaps not. I mean, it's not perhaps automatic. It's they decide that they will not sit at the table because they can't hear what's being said. That's really sad, because it's a really good opportunity to have that input. So that withdrawing from social situations because of deafness is really, really important. And addressing that is easier said than done. But making sure people have their hearing aids in before they go to the dining room is certainly something that we can help with.
And you can also provide a space that's separate to the main dining hall. Or if it's a very big noisy area, is there another smaller area that can be used for dining for those people who would find the bigger space too overwhelming, or an outdoor space, which can often be acoustically really calm and good.
So I guess a lot of that comes into when we're looking at buildings, giving people a lot of choice, that the challenge of when there's like one big dining space is everybody is herded into a spot for a meal at a certain point in time. And what can we do that actually gives a variety of choices? So somebody does want to sometimes eat in their room, that's great, but you want them to have those options. If somebody wants to be in a group of 2 or 3 people, that's great. If somebody wants to eat in front of the television, it's those options are there. The more options there are, the more likely somebody's to find that point they want to be at.
I think it's
Go on.
Can I just say, I think it's important to challenge that idea of like Mr. Jones wants to eat in his room, and to unpack why Mr. Jones might want to eat in his room. And yes, that might be his choice, but it might be his choice because everything else is not a good choice for him. So is there an alternative that he might be happy with that would be not so isolating for him?
Liz, one of the questions that came through was again challenging that question about how do you deal with carpets when there are people with incontinence. And I think it's worthwhile, again, just addressing how you're approaching that and how you would approach the different spaces around a building and what you would do.
Yeah, look, I think there are some cases where you might be tempted to put vinyl in a bedroom environment, but I think, and I know that's not what's been flagged here, but I think that is becoming more and more common to see vinyl in bedrooms for that reason, because of continence. But I think it's actually can be can make the space feel extremely unhomely, and it's often only a small percentage of people would really require that, and whereas it's becoming the default, which I think is really tricky. And there are many care homes that do put carpet into bedrooms and corridors and living spaces, and manage that well, and they may be more likely to change their carpet more often, but it's a decision that they've made because it impacts so positively in terms of the acoustic comfort and the domestic feel, and all the other benefits, and it's more slip resistant as well.
So I'll just finish up with one last question, wayfinding. Somebody was asking about artwork and is artwork sometimes too busy? So have you got like a thought to do with how you deal with that level of interior design to balance off wanting to give some point of a familiar environment, wanting to give some landmarks, and at the same time not wanting something to be too busy?
Liz, we did discuss this. You don't want to put anything scary on the walls. And you said insects would, can be really difficult. What we've found particularly is trees and flowers don't tend to cause lots of distress, and I think being very careful about that. It is good to have something people can identify with, and to have that picture and use it as a for wayfinding. But I do think we need to be careful what it is in what's in that picture.
Yeah, I think we need a whole other webinar to talk about artwork, because it's an undiscovered area. I think really, as artwork can be so useful for wayfinding, but also for engagement, for making people to make conversation about. It can really help people reflect their identity back to them and their culture. And there's so much to be said for good artwork in care homes. And often it can be very bland and quite boring and not anything, or mounted just far too high so people can't actually see it very well. So there's lots to be said in that space, definitely.
Thank you both so much for all of this. It's lots of fun, and I really enjoy listening to you and chatting with both of you, both separate in preparing this as well as now in running through the session. That concludes the session. There's a link in the Q&A to a short survey. It only takes a couple of minutes. Please do fill it out. There's also a video. The recording of this session will go up on the department's website. I think it usually takes about a week for it to go up, so you can always have a look at that. And please join us next time for the session that looks at cultivating a home at the second principle. So again, thank you, Liz. Thank you, Sue. Thank you for all the people who've helped in the background that you don't see to make this this session happen. And hopefully we'll see you again in a couple of weeks' time. Okay.
Thank you so much.
See you later.
Bye.